Welcome to a basic introduction to mechanical ventilation. This is chapter 4.1, life-threatening ventilator alarms. One of the most anxiety-provoking events in critical care is when the ventilator alarm starts going off. It seems like there are 1,000 things going on, and panic can start to set in. Fortunately, there is really only one life-threatening alarm, the high-pressure limit. And here's an approach to dealing with this alarm and the deteriorating patient. When faced with a deteriorating patient and an alarming ventilator, you need to know whether the problem is with the patient, the tube, or the ventilator. So stepwise, first, disconnect the patient from the ventilator. If this was the source of the problem, then things should start to settle down. Replace the ventilator, monitor the patient, and watch for a response. Next, while you're still bagging the patient, feel for the compliance of the patient's lungs. Difficult to bag is a clue to your problem. Next, insert a suction catheter to both clear secretions and to look for obstruction. If there's an obstruction or if the catheter is difficult to pass, then make sure the patient's not biting the tube. If the patient's not biting, then there's an obstruction and you need to prepare to reintubate the patient. However, if the patient's biting, then obviously more sedation is probably necessary. If after you've suctioned the patient becomes easier to bag, then the problem was secretions, and you can probably try to put the patient back on the ventilator again. If it is not the ventilator or the tube, then it's the patient. Now, the most concerning alarm is the high pressure alarm. It usually can occur with the low tidal volume alarm or a low minute ventilator alarm, but they are usually part of the same problem. There is a low tidal volume delivered because something is causing high airway pressures, so the ventilator is cutting off the inspiration early. Most often the cause is the patient is coughing or fighting the ventilator. Usually this is quite obvious and can be addressed with sedation and some more suctioning if necessary. The equation of motion can guide us in sorting out this problem by reminding us about the causes of airway pressure. The airway component is airflow and resistance, and in general, the airflow is not an issue, and usually it's the resistance. Causes of increased airway resistance include kinking in the tubing, bronchospasm, and secretions, which can occur in either the tubing or in the lower airways. Within the lung component of the volume and compliance, again, only the compliance is usually the culprit. A sudden fall in lung compliance can be from causes such as pulmonary edema or a pneumothorax. If the patient has an obstructive lung disease such as asthma and has been gas trapping, then hyperinflation could also be a cause. You also need to consider extrapulmonary causes that mimic a fall in the lung compliance, such as chest wall restriction from things like burns and intra-abdominal hypertension. If you're still struggling to figure out the cause of the increased pressure and the patient is reasonably stable, then you can consider doing an end inspiratory hold to measure the plateau pressure. As you can see here, if the plateau pressure is lower than the peak, then the increased peak pressure is due to an airway obstruction. On the other hand, if the peak and plateau are close, then the increased peak pressure is due to a change in the lung compliance because the plateau is high as well. So to review, when a patient is deteriorating rapidly and the ventilator is alarming, then follow a stepwise approach to sort out the cause. First, remove the ventilator from the equation and bag the patient with 100% oxygen. Next, feel the bag to get a sense of the compliance of the patient. Then try suctioning the patient to see if there's any obstruction in the tube. And finally, if none of these fix the problem, then the patient is the source. Use the equation of motion to guide your differential and treatments.